I'm Christopher Paris. I'm one of the interventional cardiologists for Cardiovascular Institute of South, and I'm speaking today for new Cardiovascular Horizons digital education series on how Cardiomems can influence congestive heart failure outcomes. I thank Dr. Walker for allowing me to speak on this topic. Here are my disclosures. Well, we all know, despite all medical advances, heart failure hospitalizations is a worsening epidemic around the world. In the cardiovascular world, we have done great with acute coronary disease, with all of our interventions, the stents. But as this has increased life expectancy, heart failure hospitalizations have been increasing and have not changed since around 2000. One part is that since the cardiovascular world with the coronary disease is getting better, more people are staying alive with low EFs, and then we're starting to see more and more patients with diastolic dysfunction. So the hospitalizations and heart failure epidemic continues to grow. Not major change has been made to the heart failure treatment plan. So therefore, the patients are getting older, more and more patients are becoming prevalent, and the heart failure admissions are increasing. One big thing with the heart failure admissions increasing is causing a growing economic burden on all of our medical care in the system, not only just in the United States, but around the world. So these numbers are here for the United States. Back in 2013 shows the amount of hospitalization and readmissions we're having. And the cost is expected to be around $70 billion in 2030. That's 2 times what it was back in 2013. Of all the care that's costing in heart failure, 50% of them are hospitalizations. So we need to find something to decrease our hospitalizations, and also by decreasing hospitalizations and heart failure, we'll give our patients a better quality of life. The major driver of all overall healthcare costs in heart failure is hospitalizations. So that's what we need to focus on if we're going to continue to promote heart failure care in the United States and around the world. So we can see here, the goal of heart failure management is to slow the progression by decreasing and preventing decompensations. Each time a patient decompensates, has to be admitted to the hospital, the myocardium takes a hit. The cardiac output goes down some, and over time, this goes down to a spiral pattern where the patient goes into end-stage heart failure and sooner or later death. Our goal is to maintain the fluid volume and prevent acute decompensations. With the acute decompensations, we can see that hospitalization usually always follows pretty soon. So that hospitalizations and decompensation can be measured, this is what's great for a study or any further advances. We all know this about the long-term mortality with increased hospitalizations is the more hospitalizations a CHF patient has, their higher risk of mortality increases also with the admissions. Now, there have been multiple studies, over 8,000 patients have been studied for non-hemodynamic-based remote monitoring to try to prevent heart failure readmission rates. The biggest things, signs and symptoms, daily weights, intrathoracic impedance pressures on ICDs and pacemakers, but none of those models, none of those studies have shown any decrease in hospitalizations. Some have even shown an increase. And it still leaves us questioning, what is the next step? How can we tackle this large beast? So the major pathogenesis of worsening heart failure is what causes the hemodynamic compromise. Fluid retention causes increased vascular resistance in the LV and left atrium, which then backs up into the pulmonary arteries, which causes fluid redistribution, and it increases our pulmonary artery pressures. Increased pulmonary artery pressures increase our dyspnea by increasing the pulmonary artery pressures themselves, and also increasing the amount of RV dysfunction. With the RV dysfunction and increased pulmonary artery pressures, which leads to hospitalizations due to dyspnea and volume overload. These are great charts for the next few slides, which shows actually the whole pathogenesis of admission from the beginning of symptoms or signs, I should say, into admission for decompensation. It was found that about 30 days out before an admission, that's when you're feeling pressures and your pulmonary arterioles begin to rise. Patients are hemodynamically stable. They're doing fine at this time. Then around day 18 to 15, your autonomic system starts to try to manage these increasing pressures while the patient is still fine, doing well. These symptoms and these changes have a negative outcome on the heart's function as they're unable to compensate for the changes, and it's leading to more and more volume and increase in pulmonary vascular artery resistance and pressures. Then around day 15 to 13, you see the increase in intrathoracic impedance increase. But by this time, it's far along the curve that it's hard to stop the process once it's going. And then you see as the process continues around day 6 to 8, that's where you see your first weight change. And then 2 days later, around day 5, you'll begin to have symptoms, and then you'll have hospitalizations. So what we try to do is have we call a proactive action that is treatable instead of a reactive action, which we've been doing in the past, and the reactive treatment is always a little too late, and patients are still being hospitalized for acute decompensation failure. If we start treating at the proactive phase, when the filling pressures are increased, we can prevent further decompensation, we can prevent further symptoms, and prevent hospitalization. In this next graph, you can see if treatment is started when the pressures are increased, you have at least a 20-day difference to where you can gain in treatment time and prevent the rest of the chain from happening. So that's why treating or looking at the filling pressures between day 30 and 25, when the patient is still stable, if we can start the treatment there, we'll prevent the rest of the chain reaction from occurring, decrease compensation, and increase patients' lives and well-being. So that's where the Cardiomems heart failure system device was designed. You can see here, it's a pulmonary artery pressure sensor. It's placed and positioned in the left lower pulmonary artery. The patients get a pillow or a monitor, which they squeeze or lay on to transmit your pulmonary artery pressures in real time. It can be daily or as much as the physician would like. And then it's downloaded into the Merlin system for evaluation. The trial that got the approval of the FDA for this device was the Champion trial. It was a randomized trial, and the second part was an open access trial. What they were trying to find, besides the signs and symptoms that we've been treating heart failure, which hasn't been working, if we can adjust medicine on PA pressures, will that reduce heart failure-related hospitalizations? So about 550 patients all got the monitor to be blinded. Half went to the treatment group, half went to the control group. The control group, they were still monitored, just no medication changes were done on the PA pressures, just on signs and symptoms as the typical treatment was prior. To be into the trial, you had to be at least class 3 New York Heart Association heart failure, either preserved or reduced EF, and you had to have at least one hospitalization within the past 12 months for CHF exacerbation. And the study went along, and what the findings were for the primary and secondary and safety endpoints, the primary efficacy showed a reduced hospitalization for heart failure patients significantly, as you see here. And the primary safety endpoint was met as there was no increased risk of placing these devices in patients. It's a very safe device and very well tolerated by the patients. Now, the secondary outpoints all met their goal. You can see either change in PA pressures, hospitalizations, days out of the hospital alive, and quality of life were either the same as control or better. One sub-analysis group I'd like to bring up and showed very great results was the patients with preserved EF, our diastolic heart failure patients. They had a great reduction of hospitalizations, just as much as our reduced EF patients. So this goes to show you how important it is to monitor pulmonary arterial pressures, because it's a fluid and volume status for both our preserved EF and reduced EF heart failure patients. Another huge issue that this study showed was that by evaluating the PA pressures, that the medical management was changed a lot more and in order to reduce hospitalizations. As you can see here, the first control column was only clinically driven by signs and symptoms. And then for the next three groups you see in the study, you have clinically driven only. admissions per year. And then you have the clinically driven plus PA pressures and PA pressures only. There was a section of physicians that did not treat just the PA pressures. They treated a patient if the PA pressures were elevated and showed signs and symptoms of decompensated heart failure. And you can see they had more admissions than the physicians who just treated PA pressures only. And that goes to show you, as a previous graph, if we hit the PA pressures early and we stop the progression, we can decrease decompensation. And this is another sub-analysis group of the PA-guided medical management. The medication changes were greatly more than the control, because you had something you were relying on with numbers to determine the pressure and to get the pressure back to a baseline standard. And all areas of heart failure management was increased by the group that was PA-guided to prevent heart failure readmissions or admissions. And then once the study was finished, they did a post-approval study. There were patients who were seen from the beginning of these devices, the Cardiomems. Well, the physicians knew to treat based on PA pressures, and you can see even a more decreased hospitalizations from their heart failure patients. Remember, decreased hospitalizations means increased quality of life and decreased mortality. So the Cardiomems heart failure system is used by the FDA, is approved to wirelessly monitor and measure the pulmonary artery pressures in patients with heart failure, either preserved or reduced, which have at least a class 3 heart failure symptoms by the New York Heart Association class, and have had at least one previous admission for heart failure decompensation within the past year. The hemodynamic data are then used by physicians for heart failure management with the goals of reducing heart failure hospitalizations. The contraindications to the system is very few. The biggest is if the patient is unable to tolerate at least dual platelet therapy or anticoagulants for at least 1 month post-implant. Some clinical considerations, but not contraindications for patients you decide on by going into the Cardiomems system are listed here. The ones I would like to bring out are patients with CKD stage 4 or 5. It's not contraindicated, but it's a clinical consideration. Also, patients who have a BMI greater than 35, you need to measure the chest circumference at the axillary level. If it's greater than 165 centimeters, then the sensor should not be implanted because of the recording and able to lay on the receiver from the patient that the body mass and width may be too large and you will not get accurate readings. So selecting the right patients, we can all see this. We all have heart failure patients with class 3 symptoms. We have 1 heart failure admission within the past 12 months. The patients who usually get this device are patients who have fluid volumes are hard to determine or manage due to possibly venous stasis with chronic kidney disease. Not sure if we should go too hard on diuretics and dry them out and hurt their kidneys versus trying to save them out from a heart failure decompensation hospital admission. When the physical assessment is challenging with some of our obese patients and patients with either preserved or reduced DF. Also, the compliance with medical care that, in order to call and be on top of them, we can reinforce the importance of these medications. And patients who live far away from the clinic where they cannot come every couple of months to be on top of their heart failure treatment, that this can be done remotely from their home, and medication changes and updates can be done daily or weekly. Remember, when assessing for their symptoms, try to talk to the patient about their last 30 days, not at the moment they're done, because that will give you a true sense of what their New York Heart Association class is. I'd like to thank everyone for listening to me. Have a great day.